Hello, everyone. My name is Michele Rayes, and I am a papillary thyroid cancer survivor and also a hypoparathyroidism patient. So hopefully, if you're listening into this session, you are here for living with hypoparathyroidism, a sometimes side effect of thyroid cancer. Now, I proudly would like to introduce Dr. Nancy Perrier from MD Anderson.
I'm happy to be talking today, and I appreciate the invitation and welcome to Houston. We're talking about the parathyroid gland, and we have talked about it being a sequelae of thyroid cancer, and it really is not a part of thyroid cancer. It is a failure of the treatment for thyroid cancer. The parathyroid glands really have nothing to do with the thyroid other than embryologically they are close in approximation. So let's just review the parathyroid and then talk through this. These are small glands that are about the size of a kernel of corn, and they are embryologically very different than the thyroid, and they reside in a position that is close to the thyroid, and they serve the biologic process of managing the body's calcium. That's really all they do. It's called parathyroid hormone. They are that hormone production is regulated by the calcium level. So when the calcium is high, that level should be low because the glands don't really need to work. When the calcium level is low, that hormone level should go high to tell the body to absorb more calcium. The regulation happens with vitamin D. That also helps the body absorb calcium. That's all vitamin D does. It helps the absorption of calcium. So they're all very tightly regulated. And PTH receptors are all over the body. They come in different categories. Some are in the brain, some are in the large muscles. Every neuroreceptor of the heart, the kidney, all require calcium for nerve conduction. And that's a very, very basic process for any first year medical student to understand the role of calcium in conduction and contraction. So, we are talking about a situation referred to as hypoparathyroidism, which means low parathyroid hormone production. And there are some genetic conditions that 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 hypoparathyroidism results from. But they are usually identified early in life, and they're very rare and unusual. But hypocalcemia and hypoparathyroidism can result, and most commonly in the United States, result from being devascularized or being bruised or being removed technically. And the workshop for the international group that studies this met at the Endocrine Society meeting recently in the spring for the second meeting, and we put together these specifics to define hypoparathyroidism so that everyone would be talking about the same thing. Not just a low calcium that transiently happens when the parathyroid glands are maybe dislodged or manipulated, but what is transient, what is permanent, and how do we define it, with what labs and in what situation. And basically, these are the conclusions about it being in an inappropriately low PTH when the calcium is low. So in a normal physiologic state, if the calcium is low, the PTH should be high. And if that PTH is not high, why is it not high? And that is hypo. And those labs should be drawn simultaneously because PTH has a half-life of 3 minutes. So when we are surgeons and operating on patients with parathyroid disease, which is a totally different disease, we can remove a parathyroid gland intentionally, and the hormone level will change in 3 minutes, and in 5 minutes, and in 8 minutes, and we can see it precipitous because of the tight regulation. So if we are talking about a post-operative situation, we're talking about a situation when the parathyroid glands are devascularized and they don't work normally. And this is happening not on the day after surgery or 2 days after surgery when they might be mildly reacting because the thyroid gland is their neighbor and was removed, but then with this is persistent. And we decided as a international group, we used to use that term at 6 months, and now we use that term at 12 months. So who is at risk for having a parathyroid problem after an operation? Body mass index is a risk factor because a bigger, deeper, thicker neck is a more difficult neck. The parathyroid glands are behind the thyroid, which can be deeper in the neck. And if the exposure needs to be adequate to look at them and to look at their blood supply, but if the body is deep, that can be a risk factor. Also, if a patient has a vitamin D deficiency before the operation, which many people in the United States don't get enough vitamin D because vitamin D is processed through the liver with UVB light between 10 and 2. It's the greatest in the northern hemisphere. And you need to absorb that on your torso where the greatest receptors are. And none of us are out exposing our torso. We're behind sunblock, we're behind tinted car windows, we're inside in the AC. So we're not all getting a lot of vitamin D. And when that calcium, when the parathyroid glands after an operation might transiently be a little shocky, telling the body to save more calcium, if the vitamin D is low, the body's ability to immediately save calcium might be a little sluggish. So that is, but notice we use the word insufficiency. That's not pure hypopara or aparathyroidism is the term that we define when there is no parathyroid hormone left in the body. And pediatric patients can be can be more difficult because the child has more reactive lymph nodes, has more brown fat, which is a normal type of fat in children that changes as they age. And if you're not an experienced surgeon that knows what parathyroid glands look like, they can look like fat and they can be confused with fat and inadvertently removed. Disease factors for patients to have hypopara, patients that have Graves' disease, which is not thyroid cancer, but it's a situation when the thyroid gland is larger, more vascular, and has an autoimmune problem in that the body is attacking the thyroid capsule and the thyroid hormone leaks out. Those patients are hyperthyroid, but because of the increased vascularity, those patients are at a little higher risk because their parathyroid glands are accustomed to a higher blood flow from their partner, the thyroid, because they do share a blood supply. Malignancy is a risk factor if the cancer is invading the surrounding structures, and those surrounding structures must be taken out in block. For instance, if the papillary thyroid carcinoma is large and invading the trachea, or if it's large or if it is invasive into the nerve and an extensive dissection. But most thyroid cancers don't do that. If the technique for removing the lymph nodes in the neck is not performed with precision, the parathyroid glands can be devascularized. In other words, the blood supply to them is about the size of dental floss. And if it's not protected, then they lose their blood supply and they no longer work. So, an operation that is more aggressive puts a patient at higher risk. And then patients that have concomitant disease, there are some patients who actually have a parathyroid problem because they have overproduction of parathyroid hormone in one gland, and the other glands are suppressed and small. And if they have concomitant thyroid carcinoma, which we sometimes find when we're doing ultrasounds on patients because we're going to be operating on their necks for parathyroid disease, those other glands are suppressed and they're a little more likely to be fragile and need to be handled with care. When we look at a recent systematic review of patients that are devascularized, in other words, the odds ratio of inadvertent, in other words, it's never written on the pre-op plan that we're going to remove parathyroid glands. That's never part of the plan. In fact, the training is that you shouldn't touch the parathyroid glands. You should treat them cautiously. You should leave them on their blood supply and sweep them laterally. It's never a plan that we're going to take out all the parathyroid glands. So it's called an inadvertent removal or excision. Well, it couldn't be saved because it was just with the lymph nodes. Okay. Well, that was a technical decision that it was with the lymph nodes and it couldn't be saved. So these are judgment things that we have to make intraoperatively. But you see here the risk of when there is inadvertent removal of the parathyroid glands, the odds ratio are much higher that the patient is going to have calcium problems afterwards. So this is what our operations look like. This is the right side of a thyroid gland. The patient's head would be over here, and the patient's feet would be over here. And this is us standing on the right side of the patient, retracting the neck strap muscles and using coker clamps, which were designed by the first surgeon to win the Nobel Prize, the early part of the 19th century, who designed these to grasp the thyroid gland. We pull the thyroid tissue up and over to expose the recurrent laryngeal nerve, to dissect out the vein. And in this, we identify the parathyroid glands, which live here. And so the technique is to dissect here so that these glands can fall this way with all of this tissue and be protected. It's called the no grab technique for not grabbing surrounding tissue. We know that we recognize that when techniques change and we're approaching, for instance, a robotic case through the axilla and coming at the thyroid this way, it might be at a higher risk to devascularize these glands. You can see this one right here. This is an illustration, an old but very good illustration from the Mayo Clinic in the 1980s. And this is in the textbook of endocrine surgery. This is one of the main, these illustrations are showing the technique, but the textbook is titled The Manual of Endocrine Surgery. And the technique is that these are where the parathyroid glands live. They're always within a sonometer of the recurrent laryngeal nerve as it approaches its insertion into the cricothyroid muscle. They share a blood supply. And again, remember, they're about 30 milligrams in size, which is about the size of the inside of a sunflower seed or a small kernel of corn. But seeing and understanding this blood supply is to move that up and over, dissect here, keep the blood supply, and move it that way. This is what the real live dissection looks like. This is a patient's head, patient's feet. This is the right side of the thyroid lobe being retracted towards the midline, meaning towards the trachea, with 2 surgical fingers. This is the carotid artery, which is the artery that goes to the brain. This is the internal jugular vein, which is the vein that drains. This is the recurrent laryngeal nerve, which is another touch point of the operation of identifying this early on, following it because it branches to protect it. And you see this, and you see this. These are the 2 parathyroid glands. So the technique is to dissect here to be able to discern those and keep them alive on a well-vascularized lateral pedicle so that they maintain their blood supply from here. Operative factors, meaning technical factors that put those glands at risk, is when someone has a central neck dissection. So we make the decision that we're going to remove the lymph nodes in that area. That means we're going to remove these lymph nodes. Our technique should be pristine. The dissection should be back here behind the nerve so that there's no recurrence. But this dissection should happen like this so that gland falls laterally. And then the dissection should happen here to remove these lymph nodes, but to move this and sweep this away. And this gland is usually the one that's at highest risk because most lymph nodes that are positive in well-differentiated thyroid carcinoma and in medullary are in this pretracheal region. So again, moving this out of the way, saving this, and taking these, which should happen on the side of the cancer, not prophylactically on the contralateral side. Because if you're going to put this side at risk, you shouldn't put the other side at risk. Reoperative necks have more scarring and they're more difficult, which is why the first operation is always the best chance to do the right operation, because anything after that is going to put us in a reoperative field. A transoral approach is certainly different because the perspective is from the midline, looking at the thyroid anteriorly, not identifying the groove of the parathyroid glands until late in the case. Surgical times that are long. The cadence of an operation is important. That operation should happen with certain cadence and steps. And if you have someone in for a long time, that means something is different about it. And we know that operative time correlates with post-operative hypopara. Low surgeon volume, because this is like knitting. When you knit every day, I can knit and look at y'all and talk because I knit every day. If I knit once a year at Christmas time, I've got to pay more attention and look down, and it's not as natural. But identifying these, discerning what's a lymph node, what's a thyroid nodule, what's a piece of fat, comes with experience, and it comes with training. And it comes with, and again, reimplantation. Sometimes if there is bulking disease or if the parathyroid gland was not kept on its pedicle and it needs to be reimplanted, that means it's moved from its normal blood supply, its normal home, and it's put somewhere foreign to it, which would be a muscle, or in some cases, if we knew we were going back in the neck, likely for other disease and it's aggressive disease, we might put it somewhere external like the arm so that we wouldn't have to put it at risk. But for that parathyroid gland to develop a blood supply, to grow an artery, grow a vein, get acclimated to the environment, and be able to make that hormone, 6 months or a year at best. So, oh, I reimplanted a para doesn't mean that tomorrow that para is going to work. There's no way it can work. Think about the physiology and the anatomy. There's no way that piece of tissue can make hormone, grow a blood supply, and function, and it can systemically be distributed through the body. So risk factors, this is again, is a nice new paper, but it does show odds ratios. Again, central neck dissection, cancer. And that's because, again, we maybe, we do a lot of operating, but the answer is not to, okay, well, let's just do half the operation, because that's not always the answer. Because then if that patient then needs a second operation, now we're only being accountable, and there are only two parathyroid glands to work from. There are two on each side. So understanding the situation and preserving all four is really important. So this is a management strategy. This is what we use. Again, it's not uncommon that in the post-operative period, the night of and the next day, that's why we usually keep patients overnight and the next day, it is to watch for bleeding, to make sure that they don't ooze. But the second reason is to check their calcium so that we can assure that that calcium level, and importantly, the PTH, because remember, it has a half-life of 3 minutes. So we know that night what it looks like. It might immediately, and usually the nadir is about at 72 hours, but immediately it's going to drop because it's going to be a little irritated that we were just there manipulating, retracting, ligating the vessels that go to the thyroid gland at the top, at the bottom, the middle thyroidal vein, manipulating. So that's to be expected. But what we do expect is that the next day it's bounced back. So at 12 and 24 hours. So for most of us, we'll draw blood the night of surgery the next morning. That gives us a 12-hour differentiation to look at those numbers. PTH is the one that's more important even than calcium, because serum calcium changes a little bit more slowly. So we have algorithms that we follow, and we don't send everyone home on calcium. We probably send, and again, when you look at the data, and there is data on this, I don't know, 1 in 5 or 1 in 6 home on a little supplement, and we expect that they're going to need a supplement for 5 days or 6 days to supplement while those glands are getting back. But it's unusual that the paras would need supplement for a much longer period of time. But you see here some of the algorithms that we use. Again, if you give too much calcium to the patient postoperatively, we go back to basic medical school. If the calcium is high, what happens to the PTH? It goes low. So if you give the patient too much calcium and you just give them, 2 grams, 3 grams, the PTH appropriately is going to stay suppressed. So if you've inadvertently removed 1 or 2 or devascularized 1 or one's on the specimen and there's only maybe 1 left and the calcium is high, then it's going to be suppressed, turn itself off. So understanding how much you give and to give it with objective information is really important for basic physiology. What high and low, this is a perfect feedback mechanism. This is our Anderson, which I'm a surgeon at Anderson. I've been here for about 21 years. About a decade ago, we did write this with one of our fellows because people like to know exactly what we do. And our nurses, our PAs, the fellows that come on the service, everyone knows. But it's a pretty straightforward algorithm about what to do the next day. But our approach is to selectively send people home with calcium supplement because we don't want everyone to go home on calcium supplement because they don't need it. And calcium makes you constipated. It's another burden you can't take with the Synthroid. They're just things along the way that we just, so this is just our protocol. Signs of acute hypocalcemia, which is what every surgery resident, intern is taught. This is what they're all panicking about the night of surgery. If they get called and the patient's, has a Shavastic sign, they all, this is like first year intern data. And if any, I assume that all of you in here have been operated on, but that intern that's seen you all night because the nurse said, he's got a little tingling, right? Because the peripheral nerves have a little tingling if there's some, and y'all know that if you're in the room, but as the body's readapting to relative hypocalcemia, you'll get a little tingling because that's nerve conduction. Remember what we said, calcium's really important for nerve conduction. And what's the longest conduction point? The tips of the fingers, right here. So you get a little tingling in them, so they're always looking for that. But you see other things, and these are, this is on every board question, every surgery resident question. You can't get out of residency without knowing this, that you're supposed to be, what they're supposed to be doing is knowing to look for that so that it doesn't happen. Reimplantation is the word that we use when we put it somewhere else. We reimplant it somewhere. Auto transplantation is when we intentionally take the parathyroid tissue out of a patient with hyperparathyroidism. And we might cryopreserve it, and we might save it and reimplant it if they recur and we need to remove other tissue. So there's a whole other disease that we're not talking here about today because it's not thyroid cancer, but I just want to clarify adjectives are really important in our specialty. And everything is not the same, but the difference between reimplantation and auto transplantation, we get asked that. I feel like I get asked that a lot. So putting that here, but that's not usually in the setting of thyroid cancer, unless we were doing a re-op and someone had bulky disease and the para was attached to the lymph nodes, and we said, okay, we're going to intentionally take it out of the central neck because as a high risk, we might be back in here because radioactive iodine, for instance, hadn't worked. So let's move it so that we don't devascularize if we have to go back. That might be maybe a child that presented with bulky disease, but rare, really rare. And this is how we do it, how we actually transplant parathyroid tissue. When someone tells you that they did that to you or that you've read about it, you mince it into millimeter size pieces. Again, you're working with something that's 30 milligrams, so it's and you mince it to increase the surface area so that it can grow a neo blood supply. And we do that in a petri dish, and then we make a single pocket in a muscle, and we introduce it into the pocket. And I actually leave two clips, two very small baby clips, so that the clips have an opacity so that we always know where that tissue is with an ultrasound, with anything, not in the bed of the neck that we're going to be re-imaging, but out of the bed. So if it's going to be lateral in the sternocleidomastoid or in the forearm, but that way we can always find it pre-operatively if we ever needed to go back. So I want to acknowledge Aaliyah Khan, Mary Louise Brandi, Dolores Schoback, Yumi Ray, their colleagues and collaborators, and we were all together in Boston, if any of you were there. And that was before the meeting. We had a pre-meeting workshop of issues because hypopara is more common than it used to be, and it's more common than it should be. And the problem is real. And how do we deal with this problem? First is we educate. Second is we prevent. And the third is we look for mechanisms and strategies to resolve the standard treatment of calcium and vitamin D that is a pain in the neck, no pun intended. But when you look at these numbers, they're just high. When you look at the United States, again, and you look at the incidence, it's related to neck surgery. And again, this is high. What are we doing? We're not training fellows right. We're not giving them enough exposure. We're having occasionalists. I don't know, but this is not like it used to be. And you can look at that data, the prevalence, and this is data that is published, yeah, it's almost 2%. We'll do 900 thyroidectomies at our institution this year. If they're that's a lot. That's too high. And this is the national number. You see across different countries, and we need to learn from this because we have a lot to learn from Korea, because Korea increased their screening mechanism of thyroid cancer in Seoul in the end of 2007, 2008, 2009. When you had your annual mammogram by ultrasound, the government said, well, we're going to also do a free ultrasound of your neck. We'll throw that in on. So then we did a lot of neck ultrasound, and we found a lot of thyroid cancer. And then we said, oh, these were incidental and small. And then it became, okay, let's find a way to take these out. And we all got really excited with new technology. This is an example of how technology kind of outweighs, and we were one of those. Okay, the robotic approaches were being performed with abdominal surgeries and other surgeries, and we thought, well, let's. And there became this surge of doing a lot of robotic thyroidectomy, and the technology was good, and the operation is innovative and good. But we then propagated a lot of people doing a lot of this surgery, not concentrating the effort. And so then we started doing a lot of people started doing thyroid cancer. And these were early thyroid cancer, but then all of a sudden we had a rage and a rash of thyroid cancer. And it was like fun to do the operation. So we had all these people doing it. And look what happened. Look at what happened. It more than almost tripled the rate of hypopara. And the point is, what was happening there technically? Because we've been doing these operations since Will and Charlie Mayo. The mortality of a thyroidectomy at the turn of the century was 23%. And in 1924, they presented at the American Medical Association the mortality of a thyroidectomy at the Mayo Clinic that had done 5,000 was less than 3%. So in 24 years, they took a high volume, and they figured out all the nuances. And we were doing that operation. So since 1924, we've been doing that same. I mean, it's not a new operation. So the point here is what happened in this short period of time. And so this is some of the epidemiology data again, and this is published data. And looking at the rate of thyroid cancer. Again, we started finding earlier thyroid cancer. We started operating. Thyroidectomy rates went up, and look, hypopara. And this is, these are the prevalence rates. And this is also data of the entire population of South Korea. And this is looking at some of the complications. And yeah, it's, these numbers are real. So at the summit, we said, let's get internationally together and put together some documents and some guidelines. And I'm just going to review some of those with you from the consensus. It's probably too much on the slide I have about 5 slides, but I'm just going to show you that, some of the things we talked about, like how to define it, making sure that, we're talking about, PTH that's drawn at a certain time. And what do we define it? What if someone's PTH is 8? How do we define it? Is it greater than 10? Does it need to be greater than 10? And I think that this is the important thing for people to take home. I think that when we start training people to just be technicians and to not follow their own patients, they miss some of the detail. Like when you make a patient hypopara, you feel it because it's painful for them and for you. You feel it and you're like, I don't ever want to do that again. What did I do wrong? Or what could I do different? Or what did I over operate? And you build this memory, this muscle memory. If you don't know these complications, then you don't feel anything, right? So I think in the era where we just do the technical operation, then we pass it off for someone else to manage, I think we're training people wrong that way, because part of all of our training is accountability for the entirety of the patient. This event, which is surgical, but working them up and working them down. And I do think that we've become a society that we're just churning and becoming kind of technical and like, okay, I'm off call, I'm done. That's not my problem. No, it kind of is your problem. And so I use that here with just the requirement of following our own patients, like knowing our own numbers. Because I think if you don't follow your patient's labs, then, in that post-operative period, you just discharge them, or you have somebody else, just send everybody home and calcium and then figure it out. You kind of won't know. So I think that's important. Some of the outcomes, again, we talked about. We talked strongly about how to confirm the diagnosis. Well, you checked ionized, you checked serum. Well, an ionized, understanding this, and it depends on at what level, because our assays become less sensitive the lower the numbers are. So the Simmons, the PTH assay machines that work. When you get to a number that's low, the sensitivity goes way off, right? The machine is designed for a sensitivity that's in the normal range. So the point here is understanding the machine, understanding the assay, what's suitable, and being really specific so that you can follow, okay, am I correcting the magnesium? Because that magnesium is part of that equation of absorption. Biotin is a drug that people take that maybe they don't always even think it's a medicine, so they don't always even report it. When they're filling out the in clinic, what medications are. Oh, I'm on none. Oh, but biotin, because that will also affect the way the PTH is reported. But we really need to know what that PTH is to know how it's responding to calcium supplementation and to magnesium and vitamin D. So we did define this. We also, are putting forth a statement on things for conventional therapy, old-fashioned conventional therapy. For instance, PPIs. If you're taking an antacid, your calcium is not going to be absorbed as well because the antacid is affecting the acidity of the gastric antrum, and the calcium that you're taking, what form of calcium are you taking, and how is that absorption? So you might be taking a lot of calcium, but it's not being absorbed. It's going straight through your GI tract. So just acknowledging that, acknowledging, ergocalciferol, you know, calciferol, whatever the formula and the form is, understanding the half-life, recognizing there are some diuretics like thiazides that help the kidney in clearance hang on to calcium as it's creating urine. And so the kidney is a filter, but it will filter and hold on to calcium. So adding a thiazide diuretic can be helpful. And so another thing that I think is underappreciated are people that have gastric bypasses. And then they end up with a goiter or a thyroid cancer and they need a thyroidectomy. And if they end up with a calcium problem, they have an absorption problem now. So, making these decisions in life they affect, but malabsorption, and now you can't absorb calcium when you need it, becomes a problem. Do you give it per rectum? Do you give it through a G tube? But these are problems that we know exist and deal with. So the levels of the conventional therapy, how should it be monitored? I think pill burden is really important. Y'all all in the room, if you're on calcium, you understand that. But the timing of it with Synthroid, particularly if you have a moderate or high risk thyroid cancer that we're trying to keep you suppressed, right? We want to keep your TSH low. We want to make sure that, that we have you on a suppressive dose. So making sure you're absorbing that and that it's not conflicting with the calcium that you're taking, again, can be complex. But we target for you all, if this is the way that are a patient, not to have a high calcium, but to have a normal low calcium so that we can continue to encourage the parathyroid glands to either wake up, regenerate, or do something. But we know that we don't want a high calcium because that will continue to suppress them. Management, if someone is postoperatively hypocalcemic, these are things that you look for that you need to know how to treat. What kind of IV calcium? IV calcium shouldn't be given through a regular peripheral IV because if it infiltrates the IV, it causes sloughing of the skin and the muscle, which can make that arm then have long-term non-use if the muscle is necrosed. So really important, not trivial things. And now we're to, what do we do with this problem that is in society that is new? And part of the solution is, well, let's find a new drug. Well, okay. We do need to find a solution, but we need to remember that we need to prevent. But the solution is, new forms of PTH. Remember, the importance of this hormone is that it has such a short half-life. So is there a form that we can create that's durable, that lasts? And in this clinical study and this drug, the data is suggesting that yes, if we do have once a day injections, it can sustain for 24 hours and avoid or potentially eliminate the supplement requirement of the conventional, 4 times a day, rocalcitriol, Oscal, whatever the regimen is. So these are titration suggestions that are effective, that continues to be confirmed. But these are good things. This is good work. Best practice, goals of therapy, take care of the symptoms, aim for the urine calcium to be normal, not low, such that the kidneys having to work too hard to reabsorb calcium. Aim for a phosphate that will balance out the calcium. Avoid problems with the kidney from the kidney having to work too hard to retain the calcium, which are kidney stones and nephrocalcinosis. And look for all the side effects or complications that happen from being hypocalcemic for long terms, like watching the eyes, watching for cataracts, watching for the eye lenses. And, I'm a surgeon, and I've been on this my whole career, endocrine surgery, and this is the point. This should not be a surgical problem. This is not a surgical disease, and so we need to be loud and strong and bold about that, because if any of us have these repeated problems, and if y'all were all, if you're all treated by me, then I need to go do another operation if I can't do this operation, and maybe occasionally have a bad outcome. But if the majority of my cases are an outcome that is this, then I'm not doing something right. Right. And that's self-assessment. That's insight. That's maturity. That's accountability. That's professionalism. That's all those things we talk about, like, wow, something's not right. My results are not quite the same as everybody else's. We've become better at this. We do have a national database called SESQUIP, which is a quality improvement bank that we ask all endocrine surgeons to put their data in. And it tracks it, and it kind of shows you compared to others, because, you think that life is good, and then you find out, wow, I only have one patient a week that's got hypocalcemia and apara. I'm doing pretty good. And then you find out, wow, you know what? That partner of mine, like, he never has it. And so then you say, like, wow, well, I need to go in his OR and see what he's doing differently. So it's a way for us to be self-aware, to tune in. So we are getting somewhere, and we are being, again, not in a punitive way, in an education way and an accountability way. And I'll leave you with these pretty flowers. I recently just walked the coast of Portugal, and these flowers were along that coast, and they were just so pretty, and they're the color of parathyroid glands. So this is a picture that's the color of a parathyroid gland. It's a beautiful, we say it looks like a jaundiced hummingbird tongue. And everyone's like, what? What did you say? Say that again. I'm like, yeah. Haven't you seen a jaundiced hummingbird? The tongue looks just like a parathyroid gland. So that's kind of our inside joke, but it's this color. So I end with this slide of all these pretty flowers that look like multiple parathyroid glands. So I hope you've learned something. And I hope you will be a part of us helping to educate and prevent and manage how we should and get better at it. Thank you.
Dr. Perrier, do you have a few minutes to take a few questions if they have them?
Sure.
Okay. Does anybody in the room have a question? Okay, I'm going to bring the microphone back to you.
Hi, my name is Veronica. How often should you be getting a PTH test? I don't think I've had one in ever, but my endocrinologist told me I was hypoparathyroidism. I take calcitriol. I take a ton of calcium. I also take antacids. So I was interested to hear your comment on antacids and
So the immediate postoperative period will tell us whether the parathyroid glands have been devascularized, right? So those that have a PTH that maybe the night of surgery went down to 18 and the next morning was 30. Well, we know that that gland can recharge. I don't care if we don't ever check that PTH again, because that parathyroid gland proved to me that they're alive and well. If your post-op calcium PTH was 18 and then the next morning it was 10, okay, well, your glands are struggling a little bit. Let's put you on a little calcium supplement and then let's wean you off of it.
so mine weren't damaged until my external beam radiation. Mine were completely fine until then, and then they just stopped working basically. But the doctor I see now is very different from my surgeon. But I haven't had a PTH test
You should.
done ever.
Yeah, you totally should, because they could have been, the external beam radiation is going to affect the tissue, maybe make, scarring and inflammation, but those glands could have been temporarily. And, you certainly need to be, but if you're on a lot of calcium and a lot of vitamin D and your calcium is, not, low normal, even if you do have viable parathyroid tissue, it's going to be suppressed. So you might be able to wean yourself off of that. It's going to be a wean, but you need the PTH to help direct that wean. So your answer, I would say to know and be consistent, 6, 8 weeks. We go by clinical signs and by how are you doing? Okay, stop your, I always, we're going to stop the vitamin D first. The real calcitriol is expensive, right? So we're gonna wean that first. Like maybe we just have you not take the morning dose and see how you do, and just slowly wean. But you need that checked, and it should be checked with the calcium. Sure. So the first one is I had a thyroid cancer and 1 parathyroid adenoma removed recently, still within the month, healing well. However, naturally my PTH dropped and I'm being supplemented. My question is about weaning off supplement to allow the PTH to rise. When this happens, if tingling occurs, is that a sign that I would need to continue supplementing, or is it push through the symptoms necessary to help PTH rise? Thanks, and excellent presentation. Thank you for the acknowledgement. If you're tingling, you know, 2 or 3 times, wait an hour, 2 or 3 more. If it happens again, repeat that. So you want to win. You need to, I wouldn't say push through it, but a little bit of tingling is a sign that your body is adjusting. Your body is, and if you had hyperparathyroidism, your body was accustomed to a high calcium. So now it's sort of having a whoa, whoa, whoa. It's in shock a little bit, like what happened here? Even normal is an adjustment for it. So the tingling is just it kind of telling you, hang on a second, what's happening? So you want to, maybe keep on your weaned regimen, but when you tingle 2 or 3 times, wait an hour, 2 or 3 more, and see if that just kind of goes away. But we do use signs as a way for a wean, but I don't totally take people off the wean with just a little bit of tingling. So I hope that question is helpful. That answer is helpful for you. But get some of the flavored Tums or get the Viactive candies. I didn't say Viagra, I said Viactive. They come in caramel, vanilla, and chocolate at CVS in a little container. You probably already know that, but just, chew on that. If you get the tingling and numbness, wait an hour. If it happens again, do it again. So the second question says, so after 7 months post-surgery, I'm still hypocalcemic. I take cholecalciferol twice a day and Tums 1,000 twice a day. Every time they lower the calcium drops to 7 or so. Okay, so you're not on enough supplement to make me think that you're aparathyroid. Aparathyroid means there's none. You have parathyroid. It's just not working well. So I wouldn't follow just the number. I would also follow the symptoms. And if you feel totally fine at 7, yeah, a little, you could probably on that dose, add it to 3 times a day, see how you do, then start weaning from 3 times a day, right? So if you did, again, I would play with that. You're on 2,000 of Tums, but maybe you change the timing in the morning, afternoon, 3 or 4, when you're finishing your afternoon activity, and then before bed. But try to change that distribution. Make sure you're not taking it with your Synthroid. But I wouldn't follow just the number. Now, in general, everyone gets nervous when a patient's calcium is in the 6s. Like, yeah, you're getting there. You might have a little, so everyone's going to get nervous. We personally are okay with you being at 7.2. That's kind of our number. Okay, 7.2, we ought to kind of get our bootstraps on. Meaning, how low are we going to let you go before you kind of stimulate that we're comfortable for you to kick that other suppressed gland in? And as a follow-up, PTH is rising slowly per blood work. Yeah, it should be. Again, you have functional parathyroid tissue, because if you were only taking 1,000 BID of Oscal, that's not, you can't sustain if you're truly aparathyroid on that low dose. So you've got something. We just need to kick it in and get it to work well. So you're on your way.
And Dr. Perrier, can you just speak to, a lot of these questions were regarding that post-surgical period that's less than a year, which is where the international guidelines say it's not necessarily permanent yet. But I would just want to clarify, in case there's people in the room or out there virtually, those don't necessarily mean the same thing if we're now 2, 3, 4 years out, and you're getting tingling and you're in the 7s or whatever.
Correct.
It's a little different.
Great point, Michelle. So, yet if you're still requiring calcium and vitamin D supplementation a year from surgery, you are hypopara, and that's what the definition means. You are hypopara. And if so, at a year, then from there, we need to manage you. We need to give you supplement, but we're not in the mode of, okay, we're going to get you in recovery. We're going to get that remnant to wake up. That remnant, if it hasn't been awakened in a year, it's gone. It's not going to get you there. And I think that's what you're referring to. Yeah, this is, I'm referring.
You don't want to let your levels get as low and dangerous when you're
not in years out. No,
not
correct.
years out.
Totally. I'm talking about, and my reference to that was in the immediate postoperative period. Like, I think he said it was like 6 weeks out or 4 weeks out. I considered it immediate, actually, within the first week or two. But
And can you speak to, real quickly, during your speech, you were talking about some of the complications. And I know most of us have already had our surgery. We've had our total thyroidectomy. So if we're hypopara, we're probably already hypopara. But there are maybe some in the room or virtually that are joining us that only had a partial thyroidectomy and may need to be going back. I met a young lady this morning who's trying to make that decision right now. She's got a reoccurrence and is trying to make that decision to go back for that second surgery. Is there any recommendations for that second surgery that you could give them, things to help prevent them from becoming permanent?
So there's nothing wrong with a total thyroidectomy, right? That was a safe operation for 100 years. And it's not a bad operation. What it requires is a respect of the parathyroid glands. So if I were the surgeon and seeing that patient who'd already had a lobe, I'm going to immediately assume, okay, the 2 parathyroid glands on that side don't work. I'm going to immediately, in my mind, think there are 2 left, because maybe those were devascularized. Because remember, if they were damaged or removed, no one will ever know, because you've got 2 others on the other side. But now when we go to operate on the other side, there are only 2 left, and they need to be handled with respect. So as a surgeon, that's like first thing in the clinic that we train the fellows. Okay, hang on a second. This is not, oh yeah, so easy, I'm swooping it. No. This is get go. Where are the paras? How do we protect them before you do anything? Because there are only 2 that need to do the sustained job. Now, there's nothing wrong. Again, I don't want anyone to think, because remember, for 100 years, we were doing total thyroidectomies and our risk of hypopara wasn't this high.
is there something you can recommend that they ask other than making sure you see an endocrine surgeon?
Yeah, see
Uh,
someone who does a lot. It comes with, see someone who knows what they're doing, looking at parathyroid glands, someone with experience. Because you've seen the size of these glands, you've seen the vascularity, and in that operation, the stakes are high. Those pairs need to be preserved. Otherwise, they'll be in this room next year.
So I'll try to make this quick. Dr. Clayman did my surgery in 9 years ago, and he's great. I could still text him to this day and Todd, how you doing? And not to single him out. He was so excited because he only had to remove one parathyroid, so the other three are fine. I'm on Loxo or sulpracatinib. I'm having incredible cramps, stomach here. There's still stuff. When I talked to Michele, I just kind of asked her, and she kind of bounced, "You need to come here," which is why I'm here. It's 9 years later. I'm coming back down to MD to get blood drawn, CT scan next week. I just asked them, can they add the PTH on the blood draw? And I don't remember seeing it, and there was no mention of it.
So remember, if your PTH was high and fine, after your surgery immediately, then they're still fine.
I had to stay in the hospital for almost 3 days.
For IV calcium?
Yeah.
Okay, so your parathyroid glands are not totally fine.
Okay.
Because if they were, you would not have needed to stay in the hospital with calcium, right? So
Okay.
you want to check, remember, we want to check together a calcium and a PTH, because maybe you do need some supplement, particularly now that you're on drug and it might be affecting your, we know there's some peripheral neuropathy with drug, and your calcium needs to be strong for that neurotransmission. So you might need supplement. Remember, it's not just that one gland was removed. It's those other glands are also at risk. If they were, again, as the blood's, and things might have changed. So I would have your calcium PTH checked. Just have them added to the labs.
Okay, great. I hope they do that. Okay, and that it could make sense, but a lot of people that are on sulpracatinib, looking at the Facebook, we have constant insight going on. There's a number of other males that came back to me and say, I'm having an exact same spot, and it's got to be the bleaching or whatever they call it of the calcium out of the body by sulpracatinib or
And those,
Tibbo.
and maybe your glands are a little less durable than they used to be, and they need a little supplement. Yeah, it's
And
certainly.
like I said, I'm not blaming
Yeah.
Dr.
And
Clayman.
if I can, do you have MEN2A?
Yes.
Okay, so that's part of the situation though, right? We have different diagnoses. That disease also comes with a calcium problem, right? Hypoparathyroidism, and managing those glands is, again, a little more complex, a little more straightforward, but another reason why your calcium PTH need to be checked.
Okay. And
And-
is there, as far as and help me out, guys, if you recall, I was asked what number I am, 919, whatever. I'm 618. I checked.
Yeah, you're
Is that-
moderate, yeah,
It's the same thing,
Yeah.
right? Okay,
Yeah.
great. Hopefully they'll add them. Thank you.
sure.
Quick question. When you're on calcium and calcitrol for 14 years, in my case, no parathyroid function, can that cause plaque to build up in your arteries, the calcium?
Probably not. So you're a hypopara and you kind of saw the long-term complications, and we talk about nephrocalcinosis, things that cluster in the kidney. We know that the eye, but your entire atherosclerotic situation of your vessels is not solely a result of hypopara. Right, that might be, you might be predisposed to atherosclerosis or hypercholesterolemia or another situation. But I don't, I don't think we can blame all of that on the hypopara, but certainly, you have layers of, your body's a little more, complex. I mean, there are layers of factors, right? But good for you for looking so good and being here and 14 years of getting your numbers just right, and and yeah. And the good news is there's hope for you that maybe you're going to get to this little once a day injection and get off of some of that calcium and vitamin D. Talk to Michelle about that.
Do you have any patients that are on calcitriol and they were on calcium with it for years and all of a sudden they had to quit the calcium because their calcium stays too high?
I would, so what you're describing is resolution of hypopara. It no longer exists because calcitriol is really helps the body absorb calcium. Do we have any patients? I don't have any patients with that exact scenario because I stopped the rosicalcitriol first because calcium is so cheap and easy. Rosicalcitriol is
Right.
expensive. It's a prescription. So if we're weaning them, someone has to go out on rosicalcitriol and calcium. I'm usually going to do calcium 3 times a day because twice a day is, in my experience, that's too long about, you get symptoms, but the the rosicalcitriol twice a day in the morning and the evening. And then we get them comfortable and then we start weaning the rosicalcitriol. And then we start weaning the calcium. Then maybe we'll go to twice a day and then we'll look at how much they're on and say, okay, take 2 500s in the morning and just 1 500 in the evening, but we continue to wean. So I just we do a different way of weaning, but I would not wean all the calcium off and leave on rosicalcitriol because you might be able to get off of that totally because all that's doing is absorbing calcium in your gut, which would be what you're taking in your normal diet if you're not taking
Right.
any supplement. So you might be okay, or whoever this person is.
Well, yeah, it's my son, but parathyroid's not working for like 15 years and all of a sudden why is he high? So she took him off
Does-
all calcium and then she goes, well, he's probably just absorbing because of his diet.
Is he an MEN patient?
Yeah.
Okay, well, he's probably has hyperparathyroidism.
Yeah.
That's so that is a totally different situation. He probably needs a parathyroidectomy. If he has high calcium, that's by definition hyperparathyroidism, and he needs an operation to remove an abnormal parathyroid gland. That's part of the syndrome. So if his calcium is high and he's an MEN1 patient, he has HPT. So we need it, you check a calcium and a PT. I mean, that's, yeah, it's calcium PTH, but that's why his calcium's high. I mean, that's a genetic disorder that, yeah.
This is a little bit different, but you mentioned earlier that people that have gastric bypass can possibly see thyroid cancer or goiters or things like that.
No, what I was referring to is if you need calcium supplementation and you have had your duodenum bypassed, that's a problem because calcium is mostly absorbed in that part of the small bowel that's bypassed.
Okay.
So then you now have a problem if in the future you need a thyroidectomy and things don't go well and you need calcium within, it's a problem. So for instance, in our clinic and training residents and fellows, you're looking on that prior surgeries. You're having the nurse, I mean, oh, you've had a gastric bypass. Don't take that patient lightly at all. They've got to
Okay.
absorb Synthroid, and if they need calcium in a bypass gut. So that was my point of,
Okay.
but often people, for instance, bypasses are pretty common. You can go drive on 59 and stop by one of the HEBs and then go get your bypass. I mean, they're common. This is a
Yes.
bariatric drive. You do
Yes.
it, but you're not thinking of the future. And then lo and behold, later in your life,
Right.
you have a thyroid cancer and you need your thyroid out. And I can tell you, because I see patients that are in real problems.
Well, my
Set.
daughter had a gastric sleeve surgery.
Okay.
And that's why I was asking if there's anything she should be doing to.
Well, her vitamin D absorption is also she's
Yes.
going to have a secondary hyperparathyroid problem because, well, not a problem, but she needs to know, and she should be educated by that surgical team and in follow-up, that she needs vitamin D supplementation. Again, that absorption of those important minerals is now different than the way the body was designed. So, and the part of the body that does best and that has cells made for that absorption is what is bypassed in many types of gastric bypass. So knowing that, right? I mean, you know, you just know it and you prepare.
Yes, yes, thank you.
Well, thank you everybody for coming. And if you have